Hello, a very good evening, everyone. I am Dr. Sumayya Nazneen, Manager Medical Services from Zuventus Healthcare Limited. On behalf of Zuventus, I welcome you all for the second episode of E-Gurukul, Solving Clinical Dilemmas by Dr. P C Mahapatra, Series 2. We have a very engaging and an important topic for today's session, that is miscarriage matters. And we are delighted to have with us none other than Dr. P C Mahapatra. As we all know, he is a distinguished personality from the world of obstetrics and gynecology. So I'd like to call upon Dr. Mahapatra to enlighten us on this topic. Over to you, sir.
Thank you, Dr. Somya, and the whole team of Juventus for again carrying out the medical and solving clinical dilemmas on the second span of events after the 28 episodes of the surgical skill development. Today we are going for the second episode of the solving clinical dilemmas for that. With this, I bring greetings and divine blessings of Lord Jagannath, and this is the second episode, thanks to the Juventus Pharma for again continuing this unstoppable E-Gurukul Series 2. And this will continue because my viewers are very much interested, the gynecologists are very much interested across the country, so that as a teacher, I am bound to carry out the instructions and the request made by them. And the academic partner is very much keen to undergo this type of program. Thank you, Juventus, for your initiative for that in clinical dilemmas. Now, today, the episode 2, I have selected a very common topic that is very much discussed over the CMEs, and there are a lot of controversies rather than consensus in it. If you go, that clinicians face a lot of problem by the guidelines, by the different recommendations, by the diagnostic armamentarium, and up till the management. And that's why it is said that if you're not able to convince, at least confuse. Believe me, my viewers, I am today within a span of, say, next an hour or so, I will not try to confuse you people, at least present some of my own experiences, and over the years, whatever I learned, I will just ventilate this across to you for the benefit of the clinicians and the clinician's perspective. Well, this is one case, a real life situation. Let us follow through these case histories. Mrs. X, 29 years, abortion 3, all spontaneous miscarriage between 8 to 10 weeks, first trimester abortions. 3D sonography reveals FIGO grade 1 myoma of 3 centimeter. We want to elucidate and find out the causes of the RPL. And in 50% of the cases, we know the cause. In 50% of the cases, we do not know the cause. But here, after 3 abortions, a 3D sonography reveals a submucous myoma, a grade 1 myoma of 3 centimeter diameter. And when we know the cause, that the myoma encroaching on the cavity, either a grade 0 or a grade 1 or a grade 2. These are really causes of the pregnancy loss, and more so about the RPL. And that's why the decision was made in the treatment guideline was a hysteroscopic myomectomy. So hysteroscopic myomectomy done, then spontaneous conception, regular ANC, and delivered a term female baby on eventful recovery. Now, therefore, the message is the place of cavity evaluation in RPL is mandatory. This cavity evaluation earlier was done routinely by hysteroscopy. Now, it's an invasive test. Even if you do a office hysteroscopy also, the alternative is that now RPL, the methodology of imaging sciences. Imaging science has developed in such a way, the man and machine has developed in such a way that nowadays 3D sonography can replace an invasive procedures of hysteroscopy. Therefore, place of cavity evaluation is there in a case of recurrent pregnancy loss. Acquired anatomical causes of uterus is of significance. We know that there are some Mullerian anomalies, which is a cause. which is congenital, but acquired anatomical causes of uterus like a pathology in the cavity. Say for example, brightest example is this myoma, submucous myoma, or a large solitary polyp will be a cause of the pregnancy loss. And therefore, in this particular case, hysteroscopic surgical treatment is a rewarding procedure for that. So this is an example which I'm giving it. This is explained causes. We know that the causes are explained here. There is definitely a cause attributable for RPL and the treatment is done accordingly. Now, second case, Mrs. Y, G3, P1, A1, L0. At 5 weeks pregnancy, first spontaneous pregnancy loss at 10th week, which is a demonstrable cardiac activity. But 2 weeks later, repeat sonography, absent cardiac activity. Second was an intrauterine fetal death due to preeclampsia at 29th week. APLA was done negative. Sonographic evidence of single gestational sick with yolk sac. No fetal node on aspirin and low molecular weight heparin. Repeat scan at 2 weeks interval. Single live fetus, 7 weeks. Continuing pregnancy. Mild PIH in third trimester. Treated with antihypertensive. LSCS was done at 35 weeks due to PIH, IUGR, and oligamenous. And a male baby of 2.2 kg delivered on eventful recovery. Now, this is an example of APLA syndrome, which is an undisputed cause of RPL. And this APLA syndrome has two criteria. One is a clinical criteria, another is a laboratory criteria, which is relevant in diagnosis. More important for the clinicians is a clinical criteria, and the modified Sapporo criteria is one of the examples for that. So there are 3 criteria in the clinical criteria. If pregnancy of 10 weeks or more with a demonstrable cardiac activity with a normal fetal anatomy, and this is one, or pregnancy loss of 3 or more before 10 weeks of gestation where the chromosomal abnormalities or the anatomical abnormalities have been excluded. And third important, one of the time when RPL was associated and related to the pregnancy loss, early pregnancy loss. But now the concept of a eclampsia and preeclampsia removed from term is attributable for APLA. So normally we know that the PIH is a disease of the third trimester, but here is a case where at 28 weeks on early third trimester, long before term preeclampsia, eclampsia, you link with the APLA syndrome, and the treatment is again an aspirin and the low molecular heparin or heparin. So aspirin and heparin are the rewarding results. Obstetric intervention at appropriate time will give a good perinatal outcome for that. And therefore, this is another second example of explained cause. We know that these are explained cause. Now third, Mrs. Jet, gravida 4, para 1, and abortion 2, living 0. First, second, spontaneous miscarriage at 8th week. Third is a preterm vaginal delivery at 29th week, early neonatal death. And there was this detection of a septum for which TCR extracervical resection of septum was done 6 months ago. Spontaneous conception, prophylactic circulase given, pregnancy continued up to 30th week. Antenatal steroid given, PPROM at 31st week. LSCS done, female baby of about 1200 grams delivered, transferred to NICU, on eventful recovery, both mother and baby doing well. So the message is anatomical congenital anomaly of the uterus, particularly the Mullerian anomaly and subsepted or septed uterus is a significant cause of recurrent pregnancy loss. Diagnostic shift is nowadays from invasive to non-invasive. No more hysteroscopic evaluation. No more no more the MRI, but the 3D sonography, the results of accuracy are almost equal to that of a hysteroscopy. So hysteroscopic correction is an ideal treatment for that, and therapy is by hysteroscopic septoplasty. And prophylactic circulase should be routinely given in this particular case. I always feel that following a resection of the septum, this is given. Reason one being that in 70% of the cases of Mullerian anomaly of septed uterus, there are associated cervical insufficiency. Second, we have done a treatment by hysteroscopy, dilatation and all that. This could be again affecting the cervical competency, and therefore these are more cases of cervical insufficiency there, and we can give it for that. So hysteroscopic correction is ideal. Prophylactic circulage routine should be given in all these cases. But in spite of all these, we find the risk of leaking in a variable duration of pregnancy. Don't think that by giving a circulage, you can continue the pregnancy up to 37 weeks for that. There are variable durations. Some may leak up as early as 26, 28 weeks. Some may not leak till the term pregnancy is there. But majority of the cases continue the pregnancy towards the fetal viability, at least for 34 weeks per pregnancy. And of course, with the neonatal care facilities available, we can make attempts in surviving even 1 kg baby for that. And intervention and NIH support is essential for this. And then another case, 27 years, married 3 years, advocate, presented with recurrent pregnancy loss A3, spontaneous abortions around 7th to 9th week, investigated, normal findings. BMI is 29. He refused for taking next chance. Anxiety and anger abused me that I'm not a guinea pig. I am a human being. Enough is enough. And I responded calmly. You are certainly not a guinea pig, but certainly a fatty woman. Reduce weight and see the result. Visit another doctor next time. After 1 year, presented with 20 weeks of pregnancy, touching my feet and exclaimed, 2 words that changed my life. Reduced weight, and I lost 20 kg of weight, and this is the result I'm getting it for that. And therefore the message, impact of obesity not to be taken lightly, and positive counseling with precise words gone deep into the minds for that, and therefore the results we are getting for that. Another case, 28 years old, both IS officers, presented with second infertility, A6 spontaneous abortions 8th week, 1 year ago. Tubal block, investigated, diagnostic and therapeutic hysterosalpingo done with tubal cannulation done, followed by IUI. Conceived following IUI in second sitting, presented with bleeding PV at 8th week, sonography, small fetal nodes in, no cardiac activity, repeat scan after 1 week, confirming missed abortion, evacuation done. Possible cause explained, worried about chances of future pregnancy and live birth, didn't conceive for 2 years, planned for IVF, conceived after first fresh transfers, missed abortion at 8th week, frozen embryo preserved, opted for another IVF center and came back with pregnancy, live fetus 7th week. Repeat scan after 2 weeks, absent cardiac activity, evacuation was done. Opted for another chance after 3 months with the frozen embryo, which we have kept it, conceived, missed abortion again with 8th week of pregnancy. Suggested for PGT IVF in higher center, successful pregnancy, 7th week, single live fetus 7 weeks, normal yolk sac, every 2 weeks scan, normal, but spotting at 12th week, scan revealed absent cardiac activity at 12th week. So this is a 6th abortion and ART pregnancies, enough is enough. Counsel for adoption, adopted a girl child, happy now with 2-year-old girl child for that. So the message, desire for motherhood is there with every mother's. Patience and perseverance pays for that. But man proposes, but God disposes for that. 26 years case of recurrent pregnancy loss A4, investigated, balanced Robertsonian translocation and karyotyping of the parents. Advised for IVF with donor gamete. Counseled about possibility of recurrence, 70 to 80% recurrence. Couldn't afford for IVF. Presented after 1 year with spontaneous conception. At age 28th week, regular ANC, normal male baby by LSCS for that. So the message what it is, chance occurrence. This is a chance occurrence where science fails. We know that the parental karyotyping, if you find a Robertsonian translocation, the recurrence rate can be predictable and advised for alternative gamete donation for that. But here, science fails and miracle happens at times, not always for that. This again at 27 years, the recurrent pregnancy loss. Abortion 7. She has lost 7 pregnancies, all spontaneous first trimester abortions, all possible investigations done normal. Attempted suicide, twice rescued. Supportive husband came with a depressed wife. And all skill of counseling failed, not keen for adoption. She didn't care for the doctor. She didn't want to listen to me. And She has a total loss of trust to the doctors and the medical fraternity for that. But suddenly I find that the lady is wearing a locket of Lord Krishna. Then I asked, do you know the birth of Lord Krishna? In which pregnancy he was delivered? Then immediately he became cheered up and said, 8th pregnancy by Devaki and Vasudeva. He became cheered up. Then she responded, and then he's emotionally hyperactive, decided for last attempt. Because I told, maybe that this time you take a chance. Maybe that Lord Krishna might be willing to come to your uterus and the 8th pregnancy. If you fail, then commit suicide, go anywhere else for that. She was emotionally hyperactive, decided for the last attempt, conceived spontaneously, uneventful antenatal period, delivered a male baby of 3 kg by LSCS, very, very happy. And then he gave the name Jagannath for that. Now, counseling has a great impact. The God's blessings, mother's strong desire, and physician's augmentation is the key to success. So, the tender loving care as proposed by Pedersen and recurrent pregnancy, unexplained recurrent pregnancy loss is a very important method of counseling. Have a confidence in the body and mind of the patient that I will be mother, and that confidence will certainly help in giving a good perinatal outcome for that. And this is the brightest example which I cite for that, and I cannot forget this particular situation. 28 years, abortion 7. First, second, third is all spontaneous first trimester abortion. Previous reports, first anembryonic pregnancy. Second and third cardiac activity demonstrated, Appler negative, subsepted uterus, 1/3, and TCR is done, septum resection done. After that, fourth pregnancy, anembryonic again. Fifth pregnancy, distal tubal pregnancy right, and lap salpingectomy done. Sixth pregnancy, considered following investigation for second infertility for 1.5 years. Single intrauterine live fetus at 8.2 weeks, NT-scan 3.2, double marker Down syndrome positive, NIPT Down syndrome confirmed, termination of pregnancy at 13.4 weeks. Seventh pregnancy, spontaneous pregnancy, failure of contraception, sonography, molar pregnancy at 9th week evacuation done. Now, she's the brightest example of all fetal medicine. The book on fetal medicine, it is there. And unlucky patient, and I'm an unlucky gynecologist. And this is a patient full and a book on fetal medicine, experienced almost all events in fetal medicine, from early pregnancy loss till ectopic pregnancy and molar pregnancy, everything she has experienced for that. And therefore, my viewers, miscarriage matters. And therefore, I want to start with these few illustrative examples and the clinical scenario. I will start what for, how far miscarriage matters. Now, fallacies of human reproduction. Human reproduction is absolutely a negative phenomenon, unlike the veterinary reproduction, which believes in multiples. If 100 exposed over there, 84 become zygotes and 16 fail to conceive and they go to infertility specialist. Out of 84 zygotes, 69 implant and produce HCG and they are chemical pregnancy, and the rest 15 there is a failure of implantation, which is a headache for the fertility specialist and reproductive medicine researchers. And out of 61, 69, 27 abort promptly in the next menses, before the next menses. These are all biochemical pregnancy, and 42 persist as a clinical pregnancy for that. Out of 42 persistence as a clinical pregnancy, clinical abortions, malformation, and other pregnancy loss occurs in 15 cases, and the survivors are only 27. Now, knowing with this data and the scientific data, every one of us should pray the Supreme Creator that we all are 27 out of 100. And that's why human reproduction is absolutely a negative phenomenon for that. So every pregnancy is wanted, every pregnancy is valuable. And this thought, if it is given to the clinicians as well as the researcher, then we can improve the perinatal outcome. And if you think that loss of pregnancy is a loss of life from the universe, you make all efforts in research and clinical clinicians' perspective to improve the perinatal outcome for that. Now, two relevant questions you have to answer as a clinicians and the healthcare provider. This is a normal thing. Every patient will ask first, doctor, why this has happened. Even with one pregnancy loss also, they ask why this has happened. You explain that 50% of the case we know the cause. These are some of the causes, genetic, anatomic, and endocrine factors, apply and other things for the immunological and other things. But 50% we don't know the cause. And sporadic abortions occur in 10 to 15% of the cases. So therefore, don't worry, you counsel like this. She is convinced. But the next question is difficult to answer. It's $1 million question. Doctor, what will happen in the next pregnancy? In spite of conceptual advances in reproductive endocrinology, immunology, genetics, and molecular biology, innovations of newer drugs and newer techniques, and technological advances, where we stand now, it draws more of controversies than consensus, more of guesswork, and more of empirical treatment for that. And therefore, miscarriage matters to whom? To the couple. Miscarriage matters to the clinicians and to the researchers. If all conglomerate together with that, I think we can find out a solution for that and give a proper treatment for that. Now, the class of RPL. What are the class of RPL? I've divided into 3 different classes of RPL. One is an undisputed cause. There are some, as we said, some few examples have seen in the case scenario. These are undisputed causes, and there are few cases where the presumptive causes and which is not established, like obesity for that. And second is unexplained miscarriage. We are not able to find out the cause by other investigations, and 50% belong to this particular category. And third, if you know the cause, treat it, and even with treatment also, there are treatment failure. And we have to address as a clinicians all this class of RPL for that and these 3. And therefore, pregnancy loss, recurrent pregnancy loss, recurrent miscarriage. These are terms which have been there since long. When we were students, where the common term was an habitual abortion. Habitual abortion is a very undignified term. Abortion, the person is habitually aborting. Then the concern that yes, it's a recurrent abortion. Then recurrent abortion name has been changed to recurrent miscarriage because abortion has become again a common dirty word for that, and recurrent miscarriage. And now we call that recurrent pregnancy loss. And recurrent pregnancy loss is now a standard definition which covers particularly for all categories of patients for that. Now, definition and a consensus. In 1946, Percy Malpass and Eastman said that if there are 3 consecutive losses, then we can say that yes, it is a recurrent pregnancy loss. Regarding the number, there is a very, very lot of difference in the guidelines, particularly the 2 world bodies, 3 bodies guidelines, which is given by RCOG, by the S3, and by the ASRM. They differ for that. And RCOG is very, very conservative. Till today, also 3 consecutive classes have been accepted by that. And in S3, they were practicing the 3. Now the task force group of S3 again has revised that it should be done for 2 pregnancy losses, enough for that. So RCOG, S3 and ASRM, there are a lot of differences as far as the guideline is concerned. But 2 has been accepted by clinicians, everybody. And what about non-consecutive? There's a big question mark. One should think about it. Number can be more than 2 or 3, but what about non-consecutive? What about 1 loss? This is important. You cannot define as a case of RPL, but now with the increasing age of the women and the pregnancy at a later age, even 1 pregnancy loss is really a problem for the couple for that, and there's very distressing thing for that. And next is, what about 5 or more losses? It's a separate category. They're poor prognostic category for that. And what about preclinical, biochemical, ectopic, molar, pregnancy of unknown location, and partner factor for that? These are some of the issues which is that now S3 has revised that the preclinical also should be included under the definition of the recurrent pregnancy loss for that. Now coming to the different causes, genetic, immunologic, anatomic, infective, endocrine, and environmental accounts for 50 to 60% of the cases, whereas 40 to 50% are idiopathic. I think the term idiopathic should be obsolete from the medical dictionary. It should be said that yes, we do not know the cause of this. And my definition of idiopathic, when a doctor is an idiot and patient's condition become pathetic, it is idiopathic. So these are the cases of 40 to 50% which are unexplained. We do not know the cause of this pregnancy loss for that. So when a doctor is an idiot and patient's condition becomes pathetic, it is rather a cryptogenic or unexplained miscarriage. We call it as an unexplained miscarriage, a better terminology than the idiopathic for that. Now the etiology, the inherent defect, environmental factor, unknown etiology, and anatomical causes, psychological causes, immunological causes, environmental causes, endocrine causes, infective causes, and genetic causes. We know that it divides into various causes revolving around the RPL for that. Now, about the clinical approach to the recurrent pregnancy loss. First and foremost is evaluation and definitive treatment. You evaluate and find out those 40 to 50% of the cases where the cause is known. But you cannot ignore the psychological aspects, because this is a very important aspect. Just finding out the cause and treatment is not enough for the clinicians. We should have a psychological aspects, and a counseling is important for that, because those cases, 40 to 50% of the cases where the cause is not known, the tender loving care can be a great help for the subsequent thing. And it has been seen that 60 to 70% of these particular group can have a normal perinatal outcome for that. Prediction of normalcy and pre-pregnancy planning. Before that, prediction of normalcy can be guessed for that if you find a cause. And pre-pregnancy planning, the brightest example where you find that yes, there could be a detectable cause or attributable, like a submucous myoma, like a septate uterus for that. And management during pregnancy, again an example, brightest example is cervical insufficiency. And in the best period during the pregnancy, it can be managed well, diagnosed well, and managed well by putting an encirclation. Obstetric intervention, again, we can have a live birth for that, but not that all cases of RPL, the indications are cesarean, but you have to take a liberal decision depending on the individualized judgment for that. But tender loving care is almost important. Apart from treatment, the psychological support is important. And from research to practice, there are many methods which are available, but ultimate goal is a quality live birth for that. Now, what are the key issues in pregnancy loss? The clinician's viewpoint. First and foremost is confirmation of the pregnancy status. This is pregnancy status should be confirmed for that. Many cases do present with a history that I have lost 3 to 4 pregnancy. How could you know? 2 months of amenorrhea and bleeding for 1 month. This could be another metropathic bleeding. So therefore, the confirmation of the pregnancy, the ASRM has categorized told that yes, confirmation of the pregnancy must be there by sonographic or by histopathological examination. Otherwise, the pregnancy can be misunderstood, and it cannot be a cause for that. It could be an anovulatory bleeding for that. Second important is isolated or a recurrent phenomena. There are cases where you find that whether this particular number can be more than 3, but it is isolated or a recurrent phenomena. And if it is isolated with sporadic miscarriage, occurs in 10 to 15% of the cases, but recurrent phenomena, if it occurs, it can be attributable to a particular cause for that. Duration of pregnancy is important. To note that in first trimester of pregnancy, I think 12 weeks of pregnancy, majority are related to the ovum or the uterus environment for that. But in latter part, particularly mid-trimester abortions, is mainly the cervical insufficiency which is there for that. Site and number is important. Sonographic scanning. What I mean to say sonographic scanning is that go deep into the sonographic reports. Majority of the sonography reports say impression, sonographic evidence of missed abortion. That doesn't have any meaning for that. If you do a sonography yourself, you find out whether the gestational sac is normal or not, if the gestational sac contains the yolk sac or not, if the gestational sac contains the fetal node or not, if the fetal node contains the cardiac activity or not. This is very important. A patient, meaning by that a cardiac activity demonstrable and after 2 weeks it has lost. That means it points out to some environmental factors outside the uterus and mainly the Upler syndrome or immunological factors which is related to that. In comparison to cases where the yolk sac is not seen or the fetal node is not seen and an embryonic pregnancy, most possibly we are dealing with some genetic defective germplasm, and these genetic factors are attributable for that also. Modality of intervention, very important, that how you go for that. And therefore, if evacuation has been done, send the specimen for at least a confirmation of the pregnancy, for histopathological evidence of pregnancy, or you can go for a parental karyotype, fetal abortus karyotyping for that. This abortus karyotyping is also of value, and recommendations have just showed a few guidelines for that. And any investigation, suppose some investigation has been performed for that. No need of doing some. A simple example I'm telling, patient do come with a HSG report. When the hysteroscopy, the cavity is normal. So no need of doing neither a hysteroscopy nor a 3D scan for that, because the cavity is absolutely normal for that. Now these are some gray zones. Very early pregnancy loss And very early pregnancy loss with the embryo or the endometrium, which is defective. Embryo decidual top is defective for that. Implantation failure is become a headache for fertility specialists and reproductive medicine specialists. ART pregnancies more frequently, more liable to pregnancy loss. Recurrent malformations we find are very often recurrent malformations, and you do a karyotyping, you don't find anything for that. Recurrent molar pregnancies, obesity, PCOS. PCOS patients do have some abnormal, I think the quality of the ovum is defective, and that gives rise to this. Substance abuse like alcohol and coffee, environmental toxins, maternal age. This is very, very important now with the changing social demography. The elderly female marries late and start pregnancy late, and therefore the maternal age is one of the determining factor for infertility as well as pregnancy loss, and this is because of the declining ovarian function for that. So that may be correlated with the AMH, with the decreased ovarian resolve. Either the pregnancy will not be there, they will be infertile, or if at all there will be pregnancy, the pregnancy loss will be there for that. There have been a lot of studies on male factor abnormality, particularly in relation to the DNA fragmentation, but yet it has not been proved with very certainty that DNA fragmentation is a value which is related to male factor abnormality for that. Stress and pregnancy wastage is another factor for that. And mixed pattern of loss, as I showed, unlucky mother. All types of pregnancy loss can be there, and therefore these belongs to the unlucky mother for that. Now, investigations of these, particularly the genetic cause for that. There is a lot of debate, and particularly the consensus is not there whether you should do an abortal karyotyping or parental karyotyping for that. And this particular thing has been changed. The karyotyping, the methodology of karyotyping has been changed now. From earlier, it was from cell culture to banding karyotyping to molecular biology, NGS and WS. Because there are some contaminations which is there and which is confusing with the cell culture, with the banding karyotyping. Molecular biological techniques, NGS and WES are much better techniques nowadays for that. There are controversies versus consensus, whether you do a abortal karyotyping or a parental karyotyping, and therefore the therapy and donor gamete and PGT are some of the options for that. Now, the recommendations is that the first pregnancy loss, the second pregnancy loss, chromosomal analysis of product of conception. If the chromosomal analysis of the product of conception is aneuploid, no further investigation has to be done for that. If unbalanced translocation, unbalanced chromosomal translocation or inversion is there, then this is a candidate for parental karyotyping for that, and parental karyotyping. And if it is euploid, full recurrent pregnancy loss workup has to be done for that. Now, immunologic. There are immunological factors like alloimmunity and autoimmunity, and applies a strong correlation with that. The diagnostic dilemmas, we say, I'm again reminding that give importance to the clinical modified Sapporo criteria, and laboratory criteria is there are many pitfalls for that. At 12 weeks, after that, you have to repeat for a transient APS cycle, which is necessary. But the treatment is very rewarding, either aspirin and heparin or low molecular weight heparin. There are merits and demerits of all these, heparin and low molecular heparin. Both are effective for that. But the merits of heparin is that the cost is low. The demerits of heparin is that you have to give 3 times in a day, and periodic PTA, PTT monitoring should be done for that. The low molecular weight heparin, the cost is more, but every day for 24 hours, 40 subcutaneous unit is enough for that, and no monitoring, PTA, PTT monitoring is required for that. The question comes, when to start, when to stop, and what are the precautions? Now, aspirin to be given periconceptionally, and even with the diagnosis of pregnancy is done, aspirin has to be continued for that. But the earlier recommendation is that heparin to be added once the pregnancy cardiac activity is demonstrated by ultrasound for that. Now, there is a change in the conception of that, and change in the concept of using the heparin, low molecular heparin, and even if the cardiac activity is not demonstrated, you start low molecular heparin or heparin as soon as the pregnancy is diagnosed. And this we get it from the evidences of infertility right from the time of the embryo transfer. We have given it, and we see that there really, if the pregnancy, the cardiac activity is not demonstrated after 2 weeks of giving this, you get a definitely cardiac activity. And when to stop? Normally we should continue it up to 34 weeks of gestation till the fetus is liable to survive. And the only in cases where there is a hereditary thrombophilia or there is a previous history of deep vein thrombosis, you have to continue it up till delivery and even 1 week after their birth for that. And the precaution, if you are using the heparin, you have to do a PTA, PTT, and in low molecular heparin, no methodology, no monitoring is required for that. Now, this is investigation of anatomical causes, the congenital anomaly of uterus. I think these are the cases where you see a uniconvate, biconvate, didelphys, septate and subseptate and arcuate. Now, subseptate and septate uterus is definitely attributable to the cause. Now, you see the surgery. This is a hysteroscopic resection of the septum, which gives a favorable outcome for that. And in acquired, there could be synechia, polyp, and myoma. Incomplete synechia is definitely a cause for that, whereas complete synechia will give rise to the infertility for that. And polyp also, multiple endometrial polyp is not a cause of pregnancy loss. It's a solitary polyp. Endometrial polyp is definitely a cause of pregnancy loss. And of course, submucous myoma, grade 0, grade 1, and grade 2. Encroaching in the cavity also, it is a cause of pregnancy loss for that. And therefore, these are the cases we see. In the below, you find that this big submucous myoma arising from the posterior wall of the uterus, and we're doing with the hysteroscopic resection with the bipolar resectoscope. Earlier, the unipolar resectoscope was being used as a glycine as a medium. Because of the toxicity of the glycine, I think we are using now, converting from unipolar to bipolar. And we have already explained these particular cases in detail in my previous episodes on the surgical management of the recurrent pregnancy loss for that. So diagnosis from invasive to non-invasive methods has been adopted, and treatment is hysteroscopic intervention in this part. For diagnosis, we are going for non-invasive methods, but for treatment, hysteroscopic septoplasty is really very beneficial and rewarding for that. Now, cervical insufficiency. Understanding the anatomy and physiology is very, very important for that. Normally, these are the cases either a congenital or acquired. In a congenital, from inherent cervical weakness in the cervix, that is really Danforth has given a very beautiful descriptions of how the proportion of muscles and fibrous tissue starting from the fundus till the cervix is important for that. In the cervix, as you go down from the fundus to the cervix, the proportion of the muscular tissue is gradually decreasing, and the proportion of the fibrous tissue is gradually increasing in the cervix for that. So these are the cases where inherent cervical weakness, where the cervical tissue contains more predominance of the muscle tissue rather than the fibrous tissue, they are going for the cervical insufficiency for that. These are the inherent weakness in the cervical composition of the cervix for that. But how to, and the acquired cases, of course, we can do with either a cervical amputation or conization or any deep cervical tear. These can be attributable for the whether it's repair. This can be attributable for the acquired causes of that. But basically, everybody prefers to give they find out the diagnosis by the length of the cervix. Earlier was by clinical methods, by finger examination, but it is not very useful for that. And therefore, when sonography came, the cervical length has become a standard procedure of investigation, and the cutoff limit is 2.5 centimeter, and above that is abnormal for that. But the main problem is that we want to look at length and strength of the cervix. It's not only the length, the strength is also important. Strength for diagnosis, the strength, plethysmography and other researchers are just working on it to find out the method, find out the strength. Because we know that in a case of inherent defect in the cervical proportion of the muscle and fibrous tissue, the length will be 5 centimeter, and all of a sudden everything will be finished within hours. It gets expelled for that, and therefore the strength and length both has to be seen for that. So the diagnostic modalities, the clinical modalities has been obsolete and it is not very accurate. The sonography has become a good methodology for that, and transvaginal sonography is really important to diagnose the length of the cervix for that. But in addition to length, you must find the cervical canal. The cervical canal, there are two types. One is a C-shaped cervix and a linear cervix. C-shaped cervix, the prognosis is much better than the linear cervix for that. And the treatment, the example, our Indian Shirodkar with the very innovative methodology called Shirodkar circlage, which I found out, and the circlage is one method. And nowadays the cup is also devised for that, pessary is devised, and progesterone. All these have been tried, and correlation has been done with all the methodology. And in the circlage also, there are various types of circlage. It can be given at the level of the internal os, that is the Shirodkar, or below the level of the internal os, the McDonald, which is a technically EG surgery, below level of the internal os, in between internal and external os. And they claimed, and these evidences show that the results are almost same. So why not adopt? The majority of the gynecologists are happy with the McDonald and surface for that. But even with that suture, the abortions is there. If that is there, then you should give it a high circlage operation, cervico-isthmic circlage for that. So there are three levels in which, one at the level of the internal os, another in between internal os and external os, and the third cervico-isthmic end circlage, or a high end circlage methodology for that. And this particular thing has been very well discussed in my previous episodes for that, in the discussion on RPL. Now, place of emergency or rescue circlage is also very, very important. Here is a case, one example, that you see the video where you find the cervix is almost fully taken up, and you see that the membranes are bulging. Now, in this particular case, whether you do some procedure or leave it alone. If you leave it alone, it is certain that it will be expelled for that. But hope against hope, if this is a method where you introduce a Foley's catheter, and bulb, you inflate the bulb, and with that inflate of the bulb, that will push the membranes up, make it a head low, give a Toshiban at least 0.9 ml just 10-15 minutes before the surgery, and IV Toshiban has to be given for that. Then you can continue the Toshiban for another 37.5 milligram, one vial for 3 hours following the procedure for that. So now you find that the cervix length is there with the Foley's catheter inflated in situ. Then the same, either a McDonald or Shirodkar, you put it. And most preferably Shirodkar, the reflection of the bladder is there, is not possible in this emergency circlage for that. And normally we favor to give a McDonald and circlage, and then subsequently, just before tying the nut, you just deflate the balloon, remove the Foley's catheter, and tighten it. And that is what which is there. And post-operative is very important. Make the patient head low and subsequently. Now, during my experience of this surgical the emergency circlage, I found that about 70% of the cases, either the encirclage, during the procedure of encirclage, the membrane ruptures, where everything is gone, you can't do anything. And because the membranes are exposed to the vagina, to the infection for a longer period, that again is causing a problem. In next 1 week, the leaking occurs for that. But rest 30% of the cases, we can continue the pregnancy, at least to a variable limit, at least to the fetal maturity or the fetal survival. And if it can continue it up to 30-31 weeks or 1 kg weight, then it's well and good to do it, and then the NICU facilities can be there, and you can have a good perinatal outcome. Even I've seen that these patients can go, there are very few patients who have gone for 37 weeks of torn pregnancy for that. But this is again a rewarding thing. At least you cannot save 100%. For at least 30% of the cases, you can see and save the baby for that. High cervico-isthmic circlage. Now those cases where the circlage even given, and then even with the circlage, the patient is leaking and the pregnancy cannot be continued, those cases, some high cervico-isthmic circlage has been planned. And these are endoscopic surgeons who have done that, and I have also experienced that endoscopically we do it and put the suture or the Marcelin tab at the level of the, above the level of the internal os, and tighten for that. This can be given in the interpregnancy interval or during pregnancy. During pregnancy, it becomes a little difficult because the uterus is enlarged, the vascularity on the side, the veins and all that, puncture of these tissues can be done for that. And therefore, the laparoscopic is. Now the problem of this laparoscopic procedure I've observed that even if you put it there and subsequently find that there's a congenital malformation not amenable to treatment, survival, and or IUFD or leaking, what will you do it? Again, you have to cut the suture because the suture is at a high level. You have to cut the suture by again doing a laparotomy or by caldotomy, you can do that. For that, we have tried a new methodology of a vaginal approach for that. And you can see the lower one is a vaginal methodology for the cervical ischemic suture, where the vaginally it can be done for that. You deflect the anterior part with the bladder high up and cut the pouch of Douglas, open the pouch of Douglas, and by doing a colpotomy, and then you just go right from the outside in the posterior fornix and the vagina one end, and then come inside laterally. You can go to the substance of the cervix so that there will not be any injury to the vessels, and then to the opposite side, and then bring out to the posterior fornix, and the suture should be on the vagina in the posterior fornix. So if at all, the benefit is that if at all there is some problem of leakage, there is a problem of IUFD or congenital anomaly, you can cut the suture from the vagina. No need of doing this again a laparotomy or the caldotomy for that also. So these are variable techniques, but the jaws are not very accurate. We put the sutures also varies. Either you can give a marceline tab or with the number 4 silk. I use a number 4 silk, which is a cheaper, cost effective for our patients for that. And same thing, either you can use for the routine McDonald or Sirotcar, or you can give for the rescue circlage or this high-end circlage, high cervical ischemic suture. You will use this number 4, and this is available number 4 silk with carved round body needle of 30 millimeter, and this is ideal for that. And that this suture either 6 o'clock or 12 o'clock you put it in a case of McDonald, or in a case of high cervical ischemic, it should be routinely at the level of the 6 o'clock position in the posterior fornix for that. So these are about the materials. Some people give a proline. The proline also, the merits and demerits are there. The merits, only merit is the lack of discharge. If you give a silk, the vaginal discharge is more often found throughout the pregnancy, whereas in a case of proline, the discharge is less. But the proline, if you make it tight, very much tight, it will have a guillotine effect and tear up the cervix. And more likely, if it's loose, then the purpose is not solved for that. And this is why the where, when, how, and what material has to be discussed with that. Now, coming to the infections, investigations of the infections. Most people think that if there is a pregnancy loss, torch is attributable. Now, for years together, we are saying goodbye to torch. There are myths and realities. Don't do torch case in a case of RPL for that. Torch is indicated in a case of pregnancy loss in late pregnancy or IUFD or the neonat showing the features of the torch infections. These are the only indications where you do a torch, but not in recurrent pregnancy loss. RPL is not required for that. Other infections like culture, histoscopic findings, the role of antibiotics for that. There has been endometritis has been attributable for that, and you diagnose it by culture or doing a hysteroscopy. You find a congested endometrial, congested surface for that, and this is really pointing out to the infections. And these are all role of antibiotics. You can give a doxycycline for a course of 2 weeks, and that can be treated for that. But no scientific evidence has been attributable for that. Last, I must say about the gut microbiome and recurrent pregnancy. A lot of researchers are now going for this gut microbiome and RPL. The gut microbiome and RPL has become a point of research, and you go that there's a lot of things to be done for that. A recent evidence from Copenhagen, I can quote it, that they're doing a research on this gut microbiome for that. This is a vaginal microbiome. They have estimated the vaginal microbiome of RPL patients versus the microbiome of a healthy donor, healthy control, and there's a lot of difference. And then they did a transplant, the vaginal they call it a transplant. That means with the healthy donor's vaginal discharge, they put it into the case of RPL and find out and done a research that the whole environment in the vaginal microbiome has been altered. And this particular case can give an idea that it becomes normal, and it is a preliminary in trial for that. They showed that yes, it is a really, there is a rewarding results for that, because these cases can give rise to a really good perinatal outcome after that. I think more of research in this line to be necessary, and gut microbiome and vaginal microbiome in relation to the RPL has really of immense value in future. It could come out for that. Now, endocrine. When endocrine comes, the number one comes about the progesterone. Progesterone lack is the first and foremost. Lot of debates and lot of empirical therapy has been there with the different types of progesterone. And now about the what type of progesterone is suitable, whether you use a micronized progesterone, whether you use the dihydrogesterone, whether you use an injectable or vaginal gel or some oral preparations. There's been a lot of debates, and scientifically we can say that the progesterone can really be of help in the first trimester pregnancy loss for that, because this is an environment which is created, and the balance between TH2 and TH1 by Raghupati and Salim Daya has become a very good research work basing on which the progesterone and the PIBF can be a very useful thing for that. Now, progesterone, what is a progesterone? Progesterone is any agent which is able to convert proliferative to secretory endometrium. Now, in the endometrium, there are two things. One is a stroma, another is a gland. If you go to the different classes of progesterone, starting from the micronized progesterone to dihydrogesterone to the 19-knot derivatives to the 17-hydroxyprogesterone, all this synthetic progesterone has an ability to convert proliferative to secretory endometrium. But the gland and stroma are different. There are few progesterone which causes stromoglandular synchronization with secretory activity. There are progesterone which causes secretory activity but stromoglandular asynchrony. Now, when we talk of embryo decidual talk or decidual environment in early pregnancy, I think the stromoglandular synchronization is important. The progesterone which have an effect on stromoglandular synchronization, they are the choice particularly for RPL, and therefore you select which progesterone is there. There are three progesterone which can be used as a pharmacotherapy. First is a micronized progesterone, second is a dihydrogesterone, third is a 17-alpha-hydroxyprogesterone caproate. Now, the 17-alpha-hydroxyprogesterone caproate is a drug which is a synthetic progesterone. It doesn't cause stromoglandular synchronization. Whereas the micronized progesterone and dihydrogesterone, these are the two progesterone which causes stromoglandular synchronization and recommended for use in pregnancy loss, in early pregnancy loss for that. And therefore, 17-alpha-hydroxyprogesterone is a good tocolytic effect, and therefore uterine quiescence is very often used for that, but not for use in the first trimester pregnancy loss. It can be used beyond the second trimester as a drug for the uterine quiescence, and therefore 17-hydroxyprogesterone caproate is a separate entity. Now the choice comes about the micronized progesterone versus dihydrogesterone. Now, what are the indications of these particular progesterone? Whether they are justified or for the sake of pharma or for the sake of the patient, we are prescribing this progesterone for that. And therefore, we have to be a very clear scientific background and really can focus on those particular cases where it should be used. And unnecessary empirical therapy in all pregnancy, I think, to be condemned for that. So the progesterone lack is very difficult to assess. Number one, if you go for a progesterone estimation and then give it, there are a number of reports which shows that you do a progesterone, there is not of value for that. Now, the area in which progesterone has been used is a luteal phase defect. Now, luteal phase defect is a point again of controversy. To diagnose LPD is a very difficult entity because two standard deviation this side and that side, and lack of 2 days has become really a problem for that. And LPD, in cases where it postulated, then a case where the oral ovulations are given, there is incidence of LPD. When there is a given the gonadotrophins are given, there is a chance of luteal phase defect for that. Now, progesterone deficiency. Frankly, the progesterone deficiency occurs in ART pregnancy. In ART pregnancy, it is mandatory for that. So in a case of IVF, where we're doing a ovum pickup and we are giving a lot of agonist or antagonist therapy, and these are liable to produce the progesterone lack. And the brightest example is Louisa Brown could have been delivered 2 years before 1978, and therefore this was not been thought of by the researchers, and they subsequently realized that progesterone supplementation is essential for that, and unnecessary abortions are there, and therefore this ART pregnancy LP, the luteal support is mandatory. There is no debate in it. But what are the drugs that can be used for that? So here the progesterone can be given, the vaginal progesterone, 8 and dose in form of 800 milligram to 1000 milligram in divided doses has to be used for that. And this either a vaginal ovule or the vaginal cream or gel which is available, or parenteral use. No place for oral, because the oral, the absorption is a doubtful value for that because of the liver bypass for that. And therefore, if at all you are giving micronized progesterone, the route is vaginal or parenteral for that. And there are a lot of trials about that in ART pregnancy, whether the dydrogesterone can be given, because it is also same as the micronized progesterone. These two progesterone have a very important stomoglandular synchronization effect and having a pure progesterone effect. It doesn't have an androgenic effect, it doesn't have an estrogenic effect, and therefore the pure progesterone effect is there. But unfortunately, all pregnancy empirical therapy, this dydrogesterone or micronized progesterone are being used, which to a little pinch of salt you must take it, and every gynecologist should use it based on the science. Something science is related for that. Now in ART pregnancies, when we say that progesterone, now of late the dydrogesterone has come out as the drug of pregnancy after the trial Lotus 2 and Lotus 3 trial. So this Lotus trial gives really a clarity that dydrogesterone in higher doses, about 40 milligram, can be used, particularly as a luteal phase support for that. And the choices varies. Those who accept, I think the BNC was the first person in India who used this Lotus trial, who used this dydrogesterone in ART pregnancy. Of course, many like Amit Patki, and in our center also we are using it. There are many centers who are using this dydrogesterone for that. Now, about the progesterone, it's not a dydrogesterone, it's a micronized progesterone. The trial is PRISM trial and a PROMISE trial. PRISM trial is spontaneous miscarriage, and PROMISE trial and unexplained miscarriage. There is a trial in Netherlands, and this particular trial taking 46 centers for that, and they've done a lot of studies on that, and they've compared whether the micronized progesterone can be a better help for them. With that use, initially they didn't find a significant difference in the use of micronized progesterone for that. This is a great trial by Kumaraswamy et al., and this has given them evidence that PRISM and PROMISE trial is of not much benefit for that. 3% increase in that is not much of benefit for that. But the NICE guidelines subsequently, and then the subgroup analysis typically shows that yes, proved that yes, progesterone can be used in a cases where there is a more than 3 pregnancy loss, or there is a subchorionic hematoma, and when there is a pregnancy loss, previous pregnancy loss, and this time there is evidence of a threatened miscarriage, there is definitely a place for the use of progesterone. Either micronized progesterone or dydrogesterone can be available. But if the problem is there is a bleeding, the problem of micronized progesterone is really to be considered as a second line option. The oral progesterone are to be used for that endeavor. And oral means dydro is the only oral progesterone which is orally effective. It's not a micronized progesterone which is oral. Because the demerits of the micronized progesterone vaginal is some compliance issue on the patients that are using the messiness of this particular vaginal application, and therefore when the alternative oral is there, they will prefer to have a oral preparation of dydrogesterone for that. And therefore, the recent NICE guideline and some of the subgroup analysis has recommended in special situations where you can give a progesterone, either a dydrogesterone or a micronized progesterone. And dydrogesterone, the main advantage of dydrogesterone is orally effective, And then second is it is user friendly. The compliance issue is there with the patients for that. Now there's a dihydro boom in the country, in India. All my pharmaceutical company are coming with the dihydro preparations for that, and the users can find out which is best for that. But one thing is very short term, that India has a capacity of manufacturing the dihydrogesterone, and there are a lot of companies, even Juveston has started this with the photon bombardment technology, and that proved that 6-dehydroretroposition they can bend it, and no need of the innovator molecule of the dufaston for that. So therefore, this is the thing which guarded opinion has to be given. Selection of the patients has to be given, and right progesterone in right time in right dose has to be given. Another thing I will tell, that the wrong thing is that how long the duration of progesterone use in these particular cases. ART pregnancy, normally many people use up to about 12 to 14 weeks, and then they discontinue when the placenta takes off, and maximum up to 20 weeks it is taken off. But don't give it for long-term use throughout the pregnancy, basing that the not only prevents preterm labor. There's some grounds on preterm labor. It has to be continued all through pregnancy. But I cannot give this message for that. I will just recommend that the pregnancy loss, either 14 weeks or 20 weeks, whichever is convenient to you, use it. Don't use it all throughout the pregnancy for that. Now, second is about androgen excess, PCOD. That is, I have already told that PCOD, the quality of the ovum is defective, and there is a expected that miscarriage can be more often with that. Hyperprolactinemia, thyroid deficiency, hypothyroid state, and subclinical hypothyroidism has not been elucidated for that, but only in a clinical hypothyroid state is used. Uncontrolled diabetes mellitus is again a cause of endocrine factors, which is definitely a factor for that. Now, coming to the evidence when we go for all these miscarriages, the guidelines comes. There are three important distinct words in medical science. One is a guideline, another is a protocol, another is a recommendation. Protocol is a strict protocol, which is very, I think not acceptable, because it's all are flexible. Medicine is dynamic, it's changing. So therefore, we change from protocol to guideline, both for the clinical management as well as for the medical legal purpose. This is really of value for that. So as regards the miscarriage, there are three guidelines which have been given by RCOG, ASRM, and S3. And these guidelines very often misguide the clinicians for that. You see, the guidelines, how it is not uniform, not standardized, all have their own opinion for that. In many cases, it's recommended. In many cases, it's not recommended. In many cases, there's insufficient evidence or a trial required for that. And therefore, you can see the various patterns, the parameters I have shown it here in relation to the RCOG and S3 and ASRM. Now, parental karyotyping, fetal karyotype, abortus karyotyping, uterine cavity assessment, resection of uterine septum, Apla syndrome, treatment of FPS, progesterone supplementation, beta-C supplementation, anticoagulants for atrial thrombophilias, thyroid functions, prolactin, torch testing, tender loving care, and steroids. Now, you see that RCOG has recommended FPS, Apla syndrome, ACA and LA, and beta-2 globulin, antiglobulin, and these are recommended. The only thing is recommended, accepted by all these guidelines of RCOG, ASRM, and S3 is Apla. But in a torch testing again, it is not recommended, approved by every agencies for that. And the steroids are not recommended by all. These are uniformly by all these three groups of the recommendations for that. But rest of the cases, we find it different. Whereas in a case of fetal karyotyping or a parental karyotyping, RCOG tells that is not recommended, and ASRM tells that is recommended, and S3 protocol is also recommended. As I have already told, in S3, the recommendation of parental karyotyping is subject to fetal karyotyping, abortus karyotyping. If the abortus karyotyping will lead to instances when there is a euploid, it did not do anything for that. And when you find some abnormality like Robertson and translocation, I think their cases you go for parental karyotyping for that. Fetal karyotyping again recommended by the RCOG as well as the ASRM protocol. but A3 have a different opinion, that ASRM has different opinion of insufficient evidence for that. So there are a lot of resection of uterine septum, insufficient evidence in RCOG, but should be considered in ASRM protocol for that. But believe me, the uterine septum, insufficient evidence, why you have taken RCOG. If you go through the deep in-depth analysis of that, particularly uterine septum varies from an arcuate uterus, the degree of septum, of arcuate to a complete septum, and this is why there is a difference. The debate occurs in a case of arcuate. The debate doesn't occur in cases where there is more than 1 centimeter length for that, and therefore in arcuate uterus, maybe that without this insufficient evidence, there is no evidence of doing that. Only in cases where you are going for in the assisted reproduction, IVF, I think even arcuate uterus, there is a resection has to be done for that. In progesterone supplementation, you see all these 3 guidelines have an insufficient evidence for that, and more research has to be required for that. And therefore, it is akin to the Kumaraswamy trial, but many other trials also showed that we are recommended for that. Beta ICG insufficient evidence is there for that. Hereditary thrombophilia recommended for second trimester losses in a RCOG and recommended as advances investigation for that. And therefore, there is, in nutshell, I can tell that there is no uniformity in the different guidelines and that. You see another, the genetics, cytogenetic analysis, hereditary thrombophilia, APLA, endocrine, uterine anomaly, male factor, and immunology. There is a various opinion on that. See, it's an example. The uterine anomaly nowadays, the 3D ultrasound has become really an important parameter as an imaging science to exclude the uterine anomaly, which almost replaces the invasive procedures of hysteroscopy for that. And one thing is that immunology, NK cell, HLA typing, not recommended outside a research context, has been approved by all the 3 guidelines for that. So basically, these guidelines are very, very strict guidelines for ICOG, starting from the number of pregnancy loss to the different investigative protocol and the treatment modality for that. And I hope the task force groups will combine and find out a consensus so that the clinicians will give a definitely very clear-cut guideline to follow that for that. So viewers, God grant me the serenity to accept the things I cannot change, the courage to change the things I can change, and the wisdom to know the difference for that. And a class of doctrines is not a disaster, it is an opportunity for that. And therefore, these are the cases where an opportunity you find out, and with the preview of the science, you can do something for that. And science fails in many cases, miracle happens in many cases, and therefore we say that there is some factor responsible. The destiny is there for that. I have given about 8 cases of really exemplary cases where you do not find anything contrary to the science. Miracle can happen with that. And for that, I think I must quote and pray this goddess, Sri Garvarakhyambigai. There is a temple of Garvarakhyambigai in Tamil Nadu, close to Trichy and Tanjavur, where lots and lots of people of recurrent pregnancy loss go there, worship there, and maybe getting results for that also. This is the faith which is there for that. And this goddess, I already say that even when the science fails, the supreme power comes in, and this is why justifies the name of Garvarakhyambigai. You think that we have a ministry, we have a portfolio. The God in heaven has also a portfolio. The prime minister is there, the president is there, and there are cabinet ministers. There are ministers which is confined and they are dealing with the finance. Lakshmi is an example for that. And there are ministers which for energy, Kali is an example for that. But particularly for pregnancy loss, there is a special goddess is there. I think I came to know later on, and I salute this goddess and say that within the purview of science, as a clinicians, you do many things, but beyond that, this goddess will really save you from this particular malady of RPL, and that can solve the purpose for that. Thank you very much, ladies and gentlemen, for giving this opportunity to me. And thanks the Juventus team for again reviving this second series of medical solving critical dilemmas.
Sir, there are questions, so Sumaya will ask the questions.
Yeah.
Okay, thank you so much, sir, for this very informative session. So the first question is from Dr. Javed from Hyderabad. What is the basic treatment protocol for repeated abortions where endometrial receptivity is poor, remaining factors being normal?
Now, this endometrial receptivity is a subject of research till today. Now, in the endometrial receptivity, there are various things which have been tried. Scratching, right from the scratching of the endometrium to scratching of the head. So scratching of the endometrium is one of the methods which is given for that. Endometrial receptivity, postulations of progesterone can enhance the endometrial receptivity. There is some GCF, the GCF trial can be given for that. And of late, PRP. PRP has been tried for that. And I didn't have any experience on PRP, but PRP by literature which I have come across, by the persons who have come across with the PRP, it is still experimental. Time will show whether there is some benefit to that.
The second question is by Pallavi from Vijayawada, Andhra Pradesh. Common cause of miscarriage.
I told the common cause of miscarriage, 50% of the case we know the cause for that. And I've categorized into this anatomical cause, categorized as alloimmunity or autoimmunity, categorized as some of the cases of endocrine causes and relation with the different progesterone to the diabetes mellitus to the PCOS and ART pregnancy for that also. So rest 40 to 50% of the cases we do not know the cause, but with that 70 to 80% will have a normal perinatal outcome by the concept of tender loving care.
Next is from Preeti from Jaipur, Rajasthan. What is the advantage of Zuvistone over natural progesterone? Is there a role of Zuvistone in endometriosis?
Oh, it's out of the box and away from the reproductive recurrent pregnancy. But definitely I will answer for that. I've already told that this Zuvistone is the 6-dehydroerythroprogesterone dihydrogesterone. And this dihydrogesterone has, I have already told about the use of dihydrogesterone and micronized progesterone. Both are effective. Both have immunomodulatory action, contrary to the different defense of women. And both doesn't have any teratogenic effect or effect on the fetus. That's very certain for that. The advantage of dihydrogesterone is that because dihydrogesterone and micronized both are products which are pure progesterone. They are free from androgens, they are free from estrogens, and they do have an effect on stomoglandular synchronization. But the advantage of dihydrogesterone is that the oral versus vaginal or parenteral. Parenteral is very painful, and micronized progesterone and vaginal micronized progesterone, you can use it, but it becomes meshy, and then there's a bleeding. They're reluctant to use it, and the compliant issue with the particular user is mainly responsible for that. And therefore, this dihydrogesterone, which is there earlier, which is not available, now the manufacturing unit has been established. The Juventus people are Juventus is from Juventus. They've done a separate manufacturing unit by the photon bombardment technology. They use the 6-dehydroerythroprogesterone progesterone, and that they have done a lot of studies comparing to the innovator molecule, what is the impurities, what is the efficacy, and what is the content, and therefore it has shown that it's almost equal. It's non-inferiority. Trials have done it, and it's not inferior to the innovator molecule for that.
Okay, sir. The last question is by Dr. Uma from Karnataka. The main reason for second trimester abortion.
Now, in a second trimester abortion, the particularly second trimester, I've already told, hinting to the cervical insufficiency. This is very, very important. Cervical insufficiency is one important cause, but apart from that, the uterine cause also responsible. The uterine cause, as I've already told, the my uterus. Here comes, if it is a first trimester abortion, think about the cavity encroachment for that. But in a second trimester abortion, intramural myoma, more than 5 centimeter, even if it has not encroached to the cavity, can give rise to this pregnancy loss for that. And therefore, mid-trimester abortions, these two things has to be found out for that.
Okay. Thank you so much, sir, for
Thank you.
investing your precious time with us. And
Sorry.
I'm sure
I beg apology for that.
I'm sure each one of us has gained valuable insights from this session.
Thank
And
you.
we look forward to see you in the next session.
Thank you.
Also, thank you,
Thank you very
everyone.
much. Thank you,
for
Team
joining.
Juventus, and thank you,
Very
my
much,
sir.
Over to you,
Thank you
sir.
very much, sir. Tech support, please. Stop the
Stop the recording. Thank you very much, sir.
Thank you, Nilesh. Thank you, Sanjay.